ఓకే.
నన్ను హోస్ట్ చేయాలి మీరు.
రావు ఇస్ హోస్ట్.
రవి సూట్ బాగుందిరా.
రికార్డింగ్ ఇన్ ప్రోగ్రెస్.
థ్యాంక్ యూ రా. నీ వల్ల మాకు వేస్ట్ అయింది టైం.
కొద్ద పగిలిపోద్ది.
రికార్డింగ్ electrophysiology testing. So it is done sometimes to differentiate it from the RVOT VT. So endomyocardial biopsy.
తీసాయి నెక్స్ట్.
So differential diagnosis. So early stages before the onset of the visual structural abnormalities. So idiopathic and the RV outflow VT is the differentials. And the cardiac sarcoidosis may occasionally mimic the ARVC morphologically and be indistinguishable even after multimodality imaging.
Correct.
So the cardiac biopsy in patients in sarcoidosis often fails to show the granulomas, but may reveal extensive fibrosis in the burnt out stage, which can be confused with the ARVC.
అది హార్ట్ ట్రాన్స్ప్లాంట్ అయ్యాక తెలుస్తుందంట అది సార్కాయిడస్ అని కొన్నిసార్లు.
Oh no. So if a patient has a ventricular dysfunction with a predominant arrhythmia, then the patient has arrhythmic cardiomyopathy. It can be ARVC, it can be LVNC, it can be anything. So we have to rule out the other disorders which are reversible. Not reversible, which are relatively which has relatively treatment.
No specific treatment.
Like sarcoid, myocarditis, Chagas, and amyloidosis. If a patient does not have predominant arrhythmia with LV dysfunction, then other disorders can be considered, like DCM. So RVOT-VT. In general, the RVOT-VT, the 12-lead surface ECG does not have baseline depolarization and repolarization changes, and also the signal average ECG can be normal. And single VT morphology is usually seen rather than multiple VT morphologies because of single exit. Usually it will be LVBP pattern with inferior axis, not a superior axis. And also there can be ECG based scoring system that has sinus. If a patient has sinus rhythm, anterior T wave inversions in lead V1 to V3, that is a major criteria, task force criteria. And this is during sinus.
ఈ స్కోరింగ్ ఏంటి ఇది దేనికి?
స్కోరింగ్ అని అంటే ఇట్ ఈస్ ఇన్ ఫేవర్ ఆఫ్ అంతే.
ఇన్ ఫేవర్ ఆఫ్ RVOT-VT.
ఇన్ ఫేవర్ ఆఫ్ ఇది ARVC.
అదే కదా.
సైనస్ రిథమ్ లో
పైన RVOT-VT అని పెట్టాను.
ఇఫ్ సైనస్ రిథమ్ ఇన్ సైనస్ రిథమ్ దేర్ ఆర్
T wave inversions ఉంటే ఇట్ ఇస్ ARVC. ఫేవర్ ఆఫ్ ARVC.
Yes. Correct. And during VT, if a QRS duration lead one is more than 120 milliseconds, that is broad, it goes in favor of ARVC. And if a patient has QRS notching and very late precordial transition, that is at lead 5 V5 or later, so it is go in favor of arrhythmic cardiomyopathy. Usually the patient has a VT which is longer, that is more than 120, it is suggestive of ACM. And also notched QRS and precordial transition, the same thing. So cardiac sarcoid. So cardiac sarcoid, so usually if you suspect a patient with 100 patients with arrhythmic cardiomyopathy, out of them 15% cases will be sarcoid. So it is very prevalent. So usually the points in favor of sarcoid are reduced LV, that is predominant LV involvement, significantly wider QRS, and
ECG లో అయితే prolonged PR నాకు తెలుసు.
right sided apical VT, not basal like RVOT, it is apical VT, and many more reducible forms of monomorphic VT, and associated respiratory and systemic symptoms, associated AV blocks, associated septal involvement, and absence of familial disease. So Brugada. So Brugada can also have delayed RV epicardial conduction, and mutations can sometimes be overlapped between Brugada, that is SCN5A, between the arrhythmic cardiomyopathy and Brugada. But the negative point is patient will be having structurally normal heart. But if a patient is found out in relatively early stage, that is in the electrical stage, the patient may be having structurally normal heart even in MRI. But in future he can progress to develop ARVC. So that's why if a patient with Brugada comes, before inserting an ICD, we have to rule out the structural heart disease by doing an MRI, because it has overlap with both sarcoid and also ARVC. These are all overlapping syndromes. So athletes, so RV enlargement compatible with the major and minor task force criteria are seen in Olympic athletes, endurance athletes. It is observed in almost major criteria is observed in 4% and minor is 1/3 of the athletes. So that's why experts recommend to take the 95th percentile as reference values, and also to use only the major diagnostic criteria, like which can be seen in only 4% rather than 32%. So the treatment, the mainstay of therapy is, one is prevention of disease progression, and the next thing is suppression and prevention of the arrhythmias and risk for sudden death. So arrhythmic events occur in approximately 10% per year, whereas sudden cardiac death is seen in approximately 2% per year. So what are the predictors of the arrhythmias? That is male gender, syncope, T-wave inversions spanning all the precordial leads, that is V1 to V6, associated RV dysfunction, prior VT, VF, and patient is actively involved in exercise and endurance athletic sports.
ఏంటిదంతా ట్రీట్మెంట్?
These are the predictors of arrhythmic events. So intense physical exertion is
V3 to V6 ఇది చూడు, మామూలుగా V1 to V3 ఉంటది, కానీ V3 to V6 ఉంటే ఇట్ ఈస్ ప్రెడిక్టర్.
అదే
కూడా ఇన్వాల్వ్ అవుతుంది.
ఓకే, ఎక్స్టెన్సివ్ ఇన్వాల్వ్మెంట్.
lateral extensive changes.
Nice.
So intense physical exertion is associated with early onset of symptoms and increased risk of VT, and therefore they are advised not to participate in athletic activity. And also anti-arrhythmic drugs may suppress a symptomatic arrhythmia, but they have not been shown to prevent sudden death. So if a patient simply comes, you should not start the anti-arrhythmic drugs to prevent sudden death. Beta blockers, they suppress the catecholaminergic triggered arrhythmias, that is especially during exercise, and they slow the progression of the ventricular dysfunction, and they have been recommended, but it doesn't prevent VT. It doesn't prevent sudden deaths. So if a patient has ventricular tachycardia, then you should start antiarrhythmic. Beta blocker should be given, along with that antiarrhythmic should be given, because it will prevent only catecholaminergic triggered arrhythmias, not all arrhythmias. So ICD is recommended in patients with aborted sudden death, syncope, or decreased LV function, and may be considered in other patients. So,
ICD, okay.
So usually the exercise prescription can be done with calculating the METs, that is the intensity of exercise, duration, and frequency in a week. They can be integrated into metabolic equivalents. So usually per week, a normal healthy adult will do 450 to 750 METs. So vigorous intensity exercises are generally those requiring more than 6 METs. These should be avoided. So risk stratification and ICD decisions. So SCD is the most feared consequence, and in young individuals, they include almost 1/4 of the sudden cardiac deaths.
Ablation gurinchi cheppaledendi? Ablation unda? Okay.
Patients receiving ICD in 5 years, they got almost 50% appropriate ICD therapies. So you can imagine the prevalence of the arrhythmias. So these are the high risk factors of major arrhythmic events. So if a patient has aborted sudden cardiac arrest or a documented VT or VF, then that is definitive indication of ICD. Or if a patient has decreased LVEF like any other cardiomyopathy, it is definite. If the patient doesn't fit into these categories, we have to risk stratify. So the high risk people include same unstable sustained dysfunction, same. So the intermediate risk will have 1 to 10% risk of arrhythmias. So that is syncope, NSVT on Holter, and some RV dysfunction, and moderate LV dysfunction, not fitting the criteria of high risk. Younger age, male sex, if it is presence in young age, తీసేయాలా? Okay. So QRS fragmentation, ivanni risk factors, and low risk are probands and relatives without risk factors and healthy gene carriers. So this is the flow chart. The high risk definitely in ICD is indicated. If a patient has more than one risk factors, class 2A, more than one minor risk factor, class 2B, and low risk, no. no ICD. So this is the
ఇది రిస్క్ స్ట్రాటిఫికేషన్ కదా.
risk stratification and ICD decision. ఇదే మెయిన్ ట్రీట్మెంట్, ఇంకేం
Okay.
లేదు ట్రీట్మెంట్.
అవునండి.
So decision for the
Okay.
ICD, this is the HRS 2019 consensus statement. So the discussion should be done with the individual regarding ICD implantation, because it is only for palliation, not a definitive curative therapy. If a patient has a cardiac arrest or sustained VT not hemodynamically tolerated, then obviously you have to implant an ICD.
Okay.
Next, if a patient has hemodynamically tolerated sustained VT or syncope suspected due to ventricular arrhythmias, so this is the class, this is also ICD is recommended, class 1. Who has a VT, who has a syncope, it is class 2A, obviously. It is not class 1. And also, 1 minute. This, the first green color thing is for arrhythmic cardiomyopathy other than ARVC. But for ARVC, even with hemodynamically tolerated VT, it is class 2A, not class 1. The first green thing is for arrhythmic cardiomyopathies, which includes all arrhythmia-related cardiomyopathies. Next, if a patient has this laminin mutation, FLNC mutation, and EF less than 45%, then that is phospholamban mutation, then it is class 2A. If a patient has a NSVT or phospholamban, these are very high risk for sudden death. So it is by default, if a genetic testing has come positive for phospholamban or laminin, it is class 2 recommendation.
Okay.
And also, if a patient has indication for pacing, then obviously ICD should be implanted rather than a pacemaker. And obviously, if it is less than 35, like any other cardiomyopathy, with a class 2 to 3 symptoms with expected meaning survival more than 1 year, ICD is class 1 recommendation for arrhythmic cardiomyopathy. For ARVC, it is for ARVC also it is same. For class 1 symptoms, it is class 2A. For class 2 to 3 symptoms, it is class 1 recommendation. And if none of these are present, then the major or the minor criteria should be seen. That is the major criteria: NSVT, inducibility of VT at EPS, and LVEF less than 50%. Then minor criteria: RV dysfunction more than 1000 VPCs and male sex. So
ఇది వేరే క్రైటీరియా మళ్ళీ.
ఇది HRS consensus guideline. More than 2 genetic mutations seen in the same person, and NSVT and PVC criteria. So if these are present, 3 major based on this 2 major and 2 minor, or 1 major plus 4, this is a class 2A recommendation. And after that, class 2B. So mostly the algorithm will tell us to implant ICD at any cost. If we are not fitting into one, we have to try the other to fit the patient into ICD algorithm.
So ARVC లో class 1 indications same EF35, resuscitated cardiac arrest.
రిసెస్టెడ్ అవన్నీ ఇంకా ఆబ్వియస్ గా అన్నిటి. కానీ ఒకవేళ దేంట్లో ఫిట్ అవ్వకున్నా కూడా పేషెంట్ మేల్ అయ్యి కొన్ని సటిల్ ఫైండింగ్స్ ఉన్న ఎన్ఎస్విటి ఉన్న ఈఎఫ్ లెస్ దెన్
క్లాస్ అది
ఇది క్లాస్ 2A. పేషెంట్ కి జెనెటిక్ పాజిటివ్ ఉన్న ఇవన్నీ క్లాస్ 2A. So catheter ablation. So catheter ablation has not shown to reduce the sudden death, but it is used when a patient with ICD will have frequent shocks. So for those people, we can do a catheter ablation, and it should be done at both epicardial and endocardial surfaces. So catheter ablation, if a patient is sustained monomorphic, it should not be a polymorphic VT, for which there is no sense in doing ablation. So if it is a monomorphic VT, then it is a class 2B recommendation. First, we have to try medical therapy. So if we have not tried medical therapy, then it is class 2B. We can straight away take him for ablation. That is class 2B. But some people will try first medicines, because the chances of success is very less in ARVC because of the modifying substrate. And if the amiodarone is ineffective or not tolerated, then it becomes class 2A. So if it is 1 minute. If those who are not tolerating amiodarone and intolerant, it is class 2A. Same thing. If a patient has only NSVT or high burdens of ventricular ectopy, then beta blockers and antiarrhythmics are the first choice rather than the ablation. If it is still not able to control, then we have to go for ablation. So arrhythmia management. So first we have to fit the patient into ICD algorithm. If it is fitting, then we have to implant. And if patient, in spite of ICD, is getting inappropriate ICD therapies, then beta blocker therapy is recommended. If a patient doesn't have a LV dysfunction, also beta blocker therapy is recommended. Which is if a patient is getting inappropriate shocks from sinus tachycardia, SVTs, or AF. AF is the most common supraventricular arrhythmia. And if a patient is not fitting into the ICD algorithm, beta blocker should be started who do not have an ICD. And if a patient has symptomatic arrhythmias in spite of ICD and beta blockers, you have to start him on antiarrhythmics like amiodarone and sotalol for the control of symptoms and also to reduce the shocks. In spite of that, if the patient has symptoms and preserved LV and RVF, we have to add flecainide in combination with beta blockers. This has some higher efficacy when two drugs are used together, like amiodarone and flecainide, or sotalol or flecainide. So, like, and the second, first is the arrhythmia management, which is the most important treatment for ARVC. And the second is the management of the ventricular dysfunction. If a patient has RV dysfunction, then we have to, there is some role of isosorbate dinitrate. Unlike in DCM, the isosorbate dinitrate, which decreases the preload, especially to the RV, will decreases the RV negative remodeling, RV adverse remodeling. So there is some role of isosorbate dinitrate in RV dysfunction patients. So in spite of the isosorbate dinitrate, if the patient is symptomatic, then we have to start like a traditional 4 pillars of the heart.
Normal మనం ఇచ్చే nitrates కదా.
Isolazine.
Isolazine.
Nitrates కాదు, isolazine. AC inhibitors or ARVs, beta blockers, aldosterone antagonists, and diuretics. So these are class 2A. The isosorbate dinitrate is class 2B. They have to be started initially. If a patient is having aneurysm, then the role of antithrombotic therapy, that is anticoagulation, comes, that is class 2B. And if a patient has atrial fibrillation, intracavitary already LV clot, and some venous or systemic embolism, that is class 1 recommendation for anticoagulation. If there is no clot also, we have to start sometimes, that is class 2B recommendation. So this is a ventricular dysfunction in arrhythmic cardiomyopathies. This has overlap with the DCM. As we can see, this is the ARVC, this is biventricular, and this is the ALVC. Usually in ARVC, the desmosome, intercalated disc, and ion channels are involved. Whereas in DCM kind of ARVC, the cytoskeleton, that structural proteins, sarcoplasmic reticulum, sarcomere, mitochondrial, these genes are involved. So how do we prevent the disease progression? If a patient is meeting the criteria for ARVC, then we have to obviously restrict him from exercises, competitive or frequent high intensity endurance exercises. So these are harm. And if he is not meeting, still he has a proband relative, then they should counsel him that they are phenotype negative but genotype positive, that competitive and frequent high intensity endurance is associated with increased likelihood of developing ARVC, even though he is not having it present. So what are the competitive exercises and endurance exercises they have defined? So downhilling, skiing, running.
తీసాయి.
Thank you.
ఏంటి హస్ట్ నుంచి చదివావా?
ఫస్ట్ బ్రౌన్ వాల్స్ 2019 హెచ్ఆర్ఎస్ ఎక్స్పర్ట్ కన్సెన్సస్ ఆర్టికల్స్.
ఓకే, అన్ని చదివావా?
ఓకేనా?
ఓకే.